Hello everyone, welcome to the Cardiac Wire Show. My name is Jake Fishman. I'm the host of the show, and we have a great interview with you today. We're at AHA 2024, and we're talking with Dr. Christian Ruff from Brigham and Women's Hospital, and we're going to be talking about a study that he is sharing later today about anticoagulant therapy that's coming out that allows better treatment for patients who also need antiplatelet therapy, and we're going to jump right into it. Welcome to the show.
Thank you so much for having us today.
So tell us about your study.
So an exciting study. Obviously, we know anticoagulation is the cornerstone of treatment for atrial fibrillation. Those patients are at a 5-fold increased risk of stroke, and anticoagulant therapy reduces that risk by 70%. Mm-hmm. But we know traditionally anticoagulants or blood thinners cause bleeding. And we were very excited to present the results of the Azalea-TME-71 trial a year ago at the American Heart Association, where we showed that Abelacimab, which is a highly potent inhibitor of factor 11, the new target for stroke prevention atrial fibrillation, reduced bleeding compared to standard of care anticoagulation with a DOAC or Rivaroxaban by 60 to 70%. That's really dramatic reductions in bleeding. And one of the things when we had that data is to look at, well, we know that a lot of patients are really high risk of bleeding in that atrial fibrillation population. And actually one of the biggest are patients who not only need to be on an anticoagulant for their atrial fibrillation, but they need to be on antiplatelet therapy because they have coronary disease, they had a heart attack, they had stenting in their heart arteries. And we know that when you add an antiplatelet on top of an anticoagulant or blood thinner, you increase the risk of bleeding by close to 50%. And that is something that just most patients can't tolerate. And it puts physicians and patients in a really difficult situation where they can't often use both, and they're trying to figure out, what do you do about the anticoagulant and stroke, and what do you do about the antiplatelet therapy for their, say, heart disease? And so we looked at those patients in Azalea, and we found that what we expect with Rivaroxaban, the DOAC, is that when you add an antiplatelet therapy, bleeding goes up by 40%. And we were very reassured that the Abelacimab reduction in bleeding was very consistent. We still saw those 60 to 70% reductions in bleeding. But when you added an antiplatelet, the rates remained very flat. And that's really fantastic because we know when you add an antiplatelet therapy on top of Rivaroxaban, the rates of bleeding are 10, 11% per year. This is a lifetime therapy. And when you add an antiplatelet on top of Abelacimab, the rates of bleeding stay low, about 3% per year. And so we know that that difference in bleeding per year allows us to really use combination antithrombotic therapy safely for patients. And that's really the optimal treatment for both their atrial fibrillation and their atherosclerotic cardiovascular disease.
Right, that's super interesting and very encouraging. When you think about the translation to the clinic and when people start prescribing it in this way, how do you see this the uptake happening?
Well, I think there's two important things. One, we know from large registries done throughout the world, is that when patients have coronary disease that's active, say, and they need to be on antiplatelet, many people actually stop the blood thinner entirely or don't take it. So when you look at patients who are untreated for atrial fibrillation, it's often because they require an antiplatelet therapy, because people are concerned they just had a heart attack and we're just going to give them their antiplatelets. But remember, that increases their risk of stroke by 5 times. And atrial fibrillation strokes are the most likely to be fatal, most likely to lead to permanent neurologic disability, which for an elderly patient usually means they no longer can live independently. And so now we hope that'll lead to significant more treatment of patients, because even if you require an antiplatelet for your coronary disease, which is incredibly common, that you won't be afraid to use a drug like Abelacimab because it's quite safe to do. And so we think that'll lead ultimately to a substantial treatment of patients who aren't treated now. And we know that population in the real world could be somewhere between 30 to 50% of patients who have a guideline indication for anticoagulation don't receive one. And that's generally because they're at a high risk of bleeding. And patients who require antiplatelet therapy at the very top of that list.
That's really interesting, and thank you so much. I mean, to be able to overcome that catch-22 of antiplatelet or anticoagulant is really amazing. So congratulations on your research. For the folks who are watching, I hope you learned a thing or two. Make sure to check out the Anthro study and Dr. Ruff study, and we'll catch you next time.
Great. Thank you so much.
Thank you.